And I'm Dr. Alvin Moss. I'm a nephrologist and a palliative care physician at West Virginia University School of Medicine. And we're going to talk about pain and symptom assessment and management in patients with kidney disease. And as you'll see, really, as we just get into the first few slides, patients define symptoms differently than we might as clinicians. And really, this will give you a whole new view of what it would mean to be patient-centered with regard to care of our patients. So my goals or objectives are to explain that symptom management is important to patients, to describe 3 systematic approaches to assessing symptoms, to address some of the most troublesome symptoms that patients report, including itching, depression, anxiety, pain, and restless leg syndrome, and then propose some approaches to manage these symptoms. So let me dwell just a little bit on this slide. And I realize it's a busy slide, but there are a couple of points I really want to make about it. And this was a study that was reported from Australia and Canada. It involved 68 patients and 24 family members. The patients were purposively sampled, which means that they were sampled intentionally to have them be generalizable to more than just the patients in those centers, to be more representative of the dialysis patient population in those 2 countries. And they were asked to rank order 68 outcomes that were important to them. And this figure shows 33 of the outcomes. And I realize that it may be hard to read, so I'll read some of this to you. But the point is, they had 12 focus groups, and at least 4 of the focus groups had to have rank ordered these 33. And starting at the top with fatigue and energy and going all the way back down to the bottom, which is calcium, parathyroid hormone, and fertility, the patients then rank ordered in importance from 0, not important at all, to 10, most important. What were their priorities for things to be managed to improve their quality of life? And at the very top, you can see that fatigue and energy, resilience, coping, ability to travel, dialysis-free time, impact on family, ability to work, sleep, anxiety and stress, drop in blood pressure, and lack of appetite were the top 10. And the researchers noted in their discussion that although researchers on hemodialysis outcomes might look at things like death, notice mortality is down here at number 14. It's below the purple line. The purple line is the top 10. Patients prioritize psychosocial and lifestyle outcomes. Patients are interested in what will help them live well. And I think that's an important thing, because as we think about symptoms, they generalize to a broader way of thinking about it. So although we might think of fatigue as a symptom, or we might think of anxiety and stress as a symptom, or whether or not you sleep well as a symptom, or lack of appetite and taste as a symptom, these actually are more categorized into what would it mean to be living well. And interestingly enough, the only symptom in the top 10 was low blood pressure or drop in blood pressure. And my point is that of these top 10, 4 out of the 10 really refer to symptoms. And then of the 33, you can see that a good half almost of the top 33 related to symptoms. So symptoms are very important to patients, and we need to pay attention to these symptoms so that we can be patient-centered in our care. And as I'll show you in a couple of slides, improve our patients' self-reported quality of life. So this is another figure from the same authors, and notice that lifestyle and psychosocial considerations were most important patients. They wanted to be normal, they wanted to maximize the capacity to function, they were interested in retaining their independence, and they wanted to focus on living well. And that's the reason why mortality or end of life was not really a high priority for them. And then notice, as you go, second thing is mortality, comorbidities, clinical complications, and symptoms was third. But to the extent that symptoms are unrelenting and severe and intrude on their quality of life and living well, then patients rank order those symptoms higher. And specifically, the symptoms that were included under symptoms were low blood pressure, feeling washed out or drained after dialysis, restless leg syndrome, and cramps. So I think the point that I really want to make from discussing this study is patients look at things differently than clinicians may, and they're interested in what can you do to help me live well. And it's important then that I show you this study, and although this is a study that I was involved in a number of years ago, nephrology researchers have consistently found the same thing, that the fewer burdensome symptoms patients report, the higher they rate their quality of life. So, for example, in this bar graph on the left, the highest score was the highest score for McGill quality of life, overall score. The highest score were patients who reported no troublesome symptoms. The middle score was those who reported only one troublesome symptom. And then clearly a significantly lower score was for patients who reported two or more burdensome symptoms. And notice that the same pattern, higher quality of life, if the physical subscale, also the patients had no symptoms, and then even a quality of life single item index, considering all aspects of your life, physical, social, spiritual, and emotional, how would you rate your quality of life on a scale of 10, excellent, as good as I can imagine, down to 0, horrible, very poor? And notice that the patients who gave themselves the highest score also had no troublesome symptoms. And then the final thing in this bar graph on the right is the satisfaction with life scale. And again, patients who had no troublesome symptoms had significantly higher self-reported satisfaction with life. So it's really important that we pay attention to things that patients say are important if we're going to improve their quality of life. And so I would say that this whole talk is really about what's important to patients, how can we be patient-centered, how can we improve their quality of life. Now, to be clear, there have been multiple studies looking at dialysis patients' symptoms, and they're pretty, it's sort of like it's round up the usual suspects. And it's things like fatigue, itching, anxiety, distress, and pain are typically over 50%. And this is a study that was done in the United Kingdom. And then this is a study that was done in Pittsburgh. And this is interesting because Steve Weisbord, the lead nephrologist on this study, developed what's called a dialysis symptom index. He identified 30 symptoms that are typically reported by dialysis patients. And in this, the symptom is listed in the left-hand column. In the middle column is how prevalent was it? And then on the right hand is how severe was it? And again, it's from 0, not troublesome at all, to 5 is troublesome as could be imagined, or very bothersome, bothers me very much. And notice 69% of the patients reported feeling tired or lack of energy, and it was among symptom severity over 3. And between 3 and 4 were the highest symptom severities. Bone or joint pain, 50% of patients reported that, with a severity scale of 3.61. And then chest pain was only reported by 10% of patients, but it had the highest reported severity. So really you can see that pain, between chest pain and bone and joint pain, pain was the highest in severity scale score. And then also, though, above 3 was itching. And itching has repeatedly been considered one of the top 3 and most troublesome symptoms that dialysis patients have. And there's a whole algorithm for how to approach that. And so Kelly or May, I'm hoping you're going to mind the chat. I see that there's some chat comments. If at some point you want to interrupt and I should address some as we go along, or if you want to hold them till the end, I'll leave that to you. Now, this is another study from the Netherlands.
Dr. Moss, Dr. Moss.
Yes. Yes.
I was going to hold them to the end. Someone did ask about having significant hand pain in the access arm and lots of joint pain.
Right.
What is the best practice?
Sure. And we're going to talk about pain, but, especially if it's in the arm where the dialysis access is, it's sometimes a neuropathy or a neuropathic pain. I don't know if the questioner can say whether it's burning, tingling, numb, shooting, stabbing, dull, aching, throbbing. I mean, those are all adjectives to describe pain. But if it's really more of the phenomenon of, like, from a dialysis steal, then actually getting your vascular surgeon to try and decrease the steel away from that hand to increase the blood flow would be the most helpful thing you could do. You could temporize with medicines for neuropathic pain like gabapentin or pregabalin or carbamazepine or imipramine. I mean, there are medicines you can use, but if you can treat the underlying problem, that's best. And I've seen that, unfortunately, a lot, and it can be quite disabling to patients. The point, and if there are other things, Kelly or May or Brandy, whoever that was, feel free to just speak up, because I can't look at the slides and also monitor the chat function well. My point with this slide is this is a study from the Netherlands. And again, the top 3 symptoms were fatigue, itching, and muscle cramps, and cramping is a type of pain. So this is pretty common. And it's interesting, Sarah Davison is a sort of internationally known nephrologist for treating symptoms. She's Canadian, and she and I have had a discussion about fatigue, and fatigue is probably the most difficult symptom to treat. And although we might want to maximize their hemoglobin and make sure their patients are well dialyzed, even when we try and do all the things that we know how to do, keep their PTH level, in a reasonable range for somebody with kidney failure, even then patients still are fatigued. And if I could just tell you anecdotally, one of the things I love to do is I take care of my patients with kidney diseases, especially the ones who've just recently had a transplant and are returning to see me in clinic. One of the questions that I love to ask them is, what's the biggest difference that you've noticed in your life since you've had the kidney transplant? And these are people whose kidney function has returned to normal with their functioning kidney transplant. And 201, I've never had a patient not identify this as the most significant change. I probably had at least 20 patients tell me this, is, doc, I have my old energy back. I feel like myself again. So clearly, if somebody says, what can we do about the fact that I just have no energy, if they are potentially a candidate for a transplant, I would definitely recommend that they pursue that route. Now, how good are we? How good are nephrologists and nephrology clinicians at identifying and treating dialysis patients' symptoms? And Steve Weisbord and colleagues have done 2 major studies on this. The one on the left is from an article in the Clinical Journal of the American Society of Nephrology in 2007, and this is from his discussion. Renal providers are largely unaware of the presence and severity of symptoms in patients who are on maintenance hemodialysis. Implementation of a standardized symptom assessment process may improve provider recognition of symptoms and promote use of symptom alleviating treatments. And so what I'm going to do, I'm going to spend a fair amount of time during this talk presenting to you things that you can do with your patients to be more standardized in your symptom assessment of them. It may be something as simple as printing off copies of the Edmonton Symptom Assessment Scale modified for patients with renal disease and having them fill it out while they're in the waiting room or while they're in their car waiting to be called into the dialysis center, depending upon how you're dealing with COVID at this point with your patients. But having them fill it out and then basically looking at their most troublesome symptoms and trying to, address those over a period of time. Well, that was an observation by Steve. And then he had a palliative care physician working with him, and they published another paper 3 years later, under treatment of symptoms in patients on maintenance hemodialysis. And they talked about the fact that a large number of patients, not only even when the symptoms were recognized, they were not being treated. So that really this is something that hopefully those of you listening to this talk, you'll be able to do a better job, because I'm going to give you some tools, some 3 different assessment tools that you can use, and then some algorithms for pain and symptom management, and even websites you can go to so that you know how to approach the symptoms that your patients will commonly report. Now, there was a Kidney Disease Improving Global Outcomes Controversies Conference on Supportive Care in Mexico City in 2013, and that led to a publication in Kidney International in 2015. And one of the areas of intense focus was pain and symptom management. And if you look at this graph, I'm going to go into the right upper quadrant here. The first recommendation was global symptom screening using tools, and I'm going to present these two tools to you, the Edmonton Symptom Assessment Scale, renal, and the integrated palliative outcomes score, renal, should be incorporated into practice. So I would encourage you, as a result of listening to me today, that you pick one of them, and maybe even you want to try both of them out for a little while, see which one you like better. I can tell you the IPOS renal is a little longer, but it gets into really how well is the patient living. And so if you take to heart that first study I presented to you, where patients really, it's most important to them, their lifestyle and their psychosocial well-being, you might want to use the IPOS renal because it is a little broader. However, if you want something that's a little simpler, you might want to use the ESAS renal. And although the dialysis symptom index can be very helpful, it has 30 items, and it's really probably too complex, except maybe to use in a research setting. So as you're assessing patients and you're identifying the symptoms, you want to use a stepwise approach. And the first line would include non-pharmacological interventions. So for example, we've said pruritus is very common and very bothersome to patients. And the first rule of thumb, I'm sure many of you listening to me know, and have even seen that many dialysis patients have extremely dry skin. And if you want to help them, certain percentage of patients, 10, 15, 20, 25% will report significant improvement just with asking them to use an oil-based soap. And this is not an ad or a commercial. I think Dove and Camay are two examples of oil-based soaps. The very worst soap they could use is one that dries out their skin. And I'm not, again, doing this to bash Ivory, but Ivory soap is a particularly bad soap for patients with kidney disease to use because it's an alkaline soap and it really does dry out the skin. So an oil-based soap, not overdoing it with showers, and then also using emollients or lubricating creams, things like Eucerin or Nuvina or Eucerna, but some of these lubricating creams that 2-3 times a day that can really take away that sense of itch. And then second line treatment can be pharmacologic if the non-pharmacologic interventions don't work. So for example, somebody who's short of breath, you may want to open the window and turn on a fan before you start doing anything else. And for somebody who's itching, certainly do all the good skin care first before you start any medicines. And then also the third step is to look at what is the evidence. So we have evidence, and in fact, the KDIGO work group said we had good evidence for uremic pruritus, sleep disturbances, restless leg syndrome, pain, and depression. There was good evidence for the value of treatment with pharmacologic agents. And then once you've done these 3 quadrants, then you get to the 4th quadrant, and you then reassess and see how your patient is reporting his or her quality of life and how they're doing with the symptom that they presented to you maybe a month ago. And I realize that the dialysis center workflows are busy enough as is, but maybe once a month you want to look specifically at symptoms and pass out the ESAS renal or the IPOS renal, and then see which symptoms are most troublesome to your patients and address them. And I can tell you from my own experience, patients are extremely grateful when you try and help them with symptoms that are very problematic for them. Now, this is the example of the Edmonton Symptom Assessment Renal Scale. And notice there are 11 items, and this was basically the Edmonton Symptom Assessment Scale was based on just the general version that had 10 that was for all patients. And then other problems, for example, problems sleeping or problems itching, were added because they were particularly problematic to dialysis patients. Notice that up at the top is up at the top is pain, rated on a scale from no pain at all to 10, the worst pain possible or imaginable. Next is tiredness, and we said that pain and tiredness are really 2 of the top symptoms. Drowsiness, sleepiness, nausea, lack of appetite, shortness of breath, depression, anxiety, well-being, overall well-being, itching, and problems sleeping, and restless legs. So this really covers a number of the major symptoms that dialysis patients report. And then you can decide as a dialysis center, as a group approaching these patients, are we only going to do the 7, 8, 9, and 10 symptoms? Or are we going to take each patient and address the 3 that are ranked highest that patient? You can develop your own approach in your dialysis center, but I do recommend that you develop a systematic approach so that you are addressing your patient's symptoms. So this is the Edmonton Symptom Assessment Renal. This is really pretty straightforward, but I know people who've used this next one, the Integrated Palliative Outcome Score Renal, really like it. Yes, it has 17 items. Yes, it's longer, but it really gives you more information about your patients. So notice question 1 is, what have been your main problems or concerns over the past 3 days? And some people have modified it to say over the past week. But the idea is this is a patient's self-report of bothersome symptoms. And this is very helpful because this is the thing you would want to address. And I do have the website, and I assume that you're going to make my slides available to all the participants. I'm not sure who, May, Brandy, Kelly, make sure that somebody sends out.
We will, Dr. Moss. This is
Okay,
Kelly.
super. Okay, super. So that you can have the website address and you can access these and you can print them off and you can hand them out to your patients after a treatment or while they're in the waiting room or before the next treatment. And then this is asking patients to rate a list of symptoms. And we've already talked about some of these because they're very much, notice there's a lot of overlap between the Edmonton Symptom Assessment Renal and the Integrated Palliative Outcome Score Renal. And that should be reassuring to us. That means we're asking the same things. That means we have agreement on what symptoms are most troublesome. But notice instead of a 0 to 10 scale on the Edmonton Symptom Assessment Renal, this is a not at all, slightly, moderately, severely, or overwhelmingly. And I can just tell you that when we're rating pain, if we were rating pain with the Edmonton Symptom Assessment Scale, we would say that a 7 to 10 is severe. And notice that a severe on this one is 3 on a, or it's actually a 3, but it's because we start with 0. So it goes 0 to 4, but a 3 out of 4 is severe, and a 4 out of 4 is overwhelmingly. So overwhelmingly, a symptom that's been overwhelmingly experienced in the last 3 days: shortness of breath, weakness or lack of energy, nausea, vomiting, poor appetite, constipation, sore, dry mouth, drowsiness, poor mobility. That's different for this one. Itching, difficulty sleeping, restless legs, changes in skin, and diarrhea. And then any other symptoms. So this really gives the patients an opportunity in case they're having symptoms that aren't part of the usual symptoms dialysis patients report. And then notice this is asking in a different way about anxiety or worry, again, from 0, which is never, to always, 4. Have any of your family or friends been anxious or worried about you? So it gets into relationships. And then here's depression, which was also asked on the ESAS renal. Have you felt at peace? Now that's a really good, again, we're tapping into sort of psychological well-being and are things affecting their lifestyle or not. And notice that the scale now goes from always to not at all. Have you been able to share how you are feeling with your family or friends as much as you wanted? So this is really getting into, are they supported in their relationships? Again, always to not at all. And have you had as much information as you've wanted, which is really a good question in terms of, how are the healthcare providers doing in answering your questions and providing you with what you want to know? And of course, if we think about it, patients want information to feel empowered and to feel in control. And so if they don't have as much information as they want, that can be distressing to them because, how we say knowledge is power, but if you don't have the knowledge, if you don't have the information, then you can feel somewhat helpless and somewhat out of control. And none of us like to feel that way. This next question, have any practical problems resulting from your illness been addressed? And then this is a question about, are they dealing with some practical problems? Are they having trouble getting to dialysis, trouble getting their meds, problems with their living situation, problems with their finances? And question 10 is, how much time do you feel has been wasted on appointments relating to your healthcare, waiting around for transport or repeating tests? It goes from none at all to more than half a day wasted. And then it even asks, how did they complete the questionnaire on their own with help from a member of the staff? You can see, so let me go back to this. You can see the IPOS renal gets you a whole lot more information about how your patient is doing psychosocially than just the ESAS renal, but it gives you a whole lot more information. And honestly, if you're going to be asking those questions, ideally, you have to have somebody in your dialysis center who's prepared to work with the patients when they say that they are really having significant problems, practical problems, dealing with a lot of time being wasted. So really, ideally, your social workers or your nurses might be free to help patients with that, but I don't know your dialysis center and if that's true or not. So let me stop here. We're sort of halfway through. And Kelly, why don't you let me know if there are some things we should talk about? This sort of is the assessment part. And as we've said, renal providers are not good at assessing patient symptoms. So I've given you two validated tools for dialysis patients. Either one you can access and use in your care of patients. Questions, Kelly, that we should address?
Dr. Moss. Yes, Megan asks, have you found success in comparing numeric totals over time using these tools, or are the benefits more related to the conversations that are open during the visit by asking these questions?
So, excellent question. And yes, you can. I mean, certainly as I've treated pain in my patients, for example, over a period of time, I've looked at their pain scores. And it's been very gratifying to see their pain scores drop from like a 7.6 to a 1.8 over a 4-week period of time. We did a study in which we were intensively, we said this month we're focusing on pain in our patients. And we were able to clearly see a difference. And not only that, but as Megan suggests, and our conversations really indicated to us the benefit. Not only were their numerical scores less, but we were hearing things like, as we were treating pain, doc, I can finally sit through a dialysis treatment without my back killing me because I have something that's really helping my back pain. Or doc, my legs feel better and I can actually walk to the mailbox and get the mail myself because it doesn't hurt me so much to walk. So the relationships improve, but also the numbers. We like to say the numbers don't lie. Nephrologists love to look at numbers. But one of the reasons why we like to look at numbers is, sometimes in other aspects of medicine, you're having trouble figuring out, is this really real, or is the patient just malingering? Are they complaining? But when the BUN's 90 and the creatinine's 8, the numbers tell us the patient really has kidney disease and kidney failure. I hope I've sort of answered Megan's question. Are there others, Kelly?
Not currently, no. You can continue.
Okay, all right. So let's go on to treatment then, and let's start with restless legs. And notice there's a definition of restless legs in the upper right-hand corner: an irresistible impulse to move one's legs, often accompanied by unpleasant sensations in lower limbs. Such urges or sensations start or are made worse by periods of inactivity. People typically report restless legs are worse at night when they're in bed. Such urges or sensations are partly or completely relieved with movement. Such urges or sensations are more severe in the evening or at night than during the day. And the clinical criteria are not caused by other medical or behavioral conditions that could mimic restless legs, like muscle aches or venous stasis disease or leg cramps. So there's an international definition, and that's there. And then in the left-hand side, they suggest the way to do it is to take a detailed history and to compare it with the criteria that I just read you from the International Restless Legs Syndrome Study Group, to explore the option of intradialytic aerobic exercise, 30 minutes of cycling between hour 2 and 3 of dialysis can sometimes help with restless legs on dialysis. I know some dialysis centers where they had cycles available for patients, but most don't. And then there's medication treatment. And honestly, this is one of those symptoms where it's been most gratifying because patients really do seem to respond to low-dose medications. And they suggest either things like ropinirole or low-dose gabapentin, starting at even 100 milligrams, maybe 3 times a week after dialysis. But starting with just getting them up, getting them to move around, getting them to exercise, and then low-dose medications at night to treat restless leg syndrome. And what do they say down here? 10 to 20% of long-term dialysis patients have restless leg syndrome when the strict diagnostic criteria are applied, and approximately 80% of restless leg syndrome sufferers also experience the sleep disorder, periodic limb movements. So there are a lot of symptoms, and it seems to go along with with having kidney disease, and it's associated with other disorders. And so the first thing would be non-pharmacologic measures. Again, remember, always look at the non-pharmacologic measures first. Good sleep hygiene, no caffeine, not a lot to eat or drink several hours before bedtime, no other stimulants, perhaps upping the dialysis regimen, getting them better dialyzed, having them do some walking if they can, some aerobic exercise, treating iron deficiency, treating hyperphosphatemia, and then pharmacologic approaches might include, these various drugs that we've mentioned that have been found to be a benefit. So I sort of commend you, restless leg syndrome, if you approach it in a systematic fashion. My experience is that more than half the time you're going to really have patients reporting an improvement in their symptoms. Now, anything about restless legs, Kelly, before we move on to pain?
No, sir.
Okay, all right, so let's talk about pain. So the first thing is, if you look in the right-hand column, one of the things that you can all walk away with is there are definitely medicines you should not be giving to dialysis patients because, for example, morphine, codeine, meperidine, that Stemrol, we hardly ever use Demerol anymore. Propoxyphene, that was in Darvon, we don't use that anymore, at least not in this country. But the morphine and the codeine are still used at times in dialysis patients. And then we worry, why are they sleepier? Why are they jerking more? Why have we seen mental status changes? And it's because the morphine metabolites are excreted through the kidneys. And if the kidneys are not working because the patient is in kidney failure and on dialysis, it's just not a good medicine to use. So I pretty much say stage 3 kidney disease on, don't use morphine and codeine. So what do we recommend? And those are the green over here. Acetaminophen is safe. It's not a renally excreted active metabolite. Hydromorphone in smaller doses, especially while patients are on dialysis, is okay. But if patients stop dialysis, they're still taking hydromorphone, they can get what's called opioid neurotoxicity, and they can have jerking, and they can have somnolence, and even could progress to seizures. So I'm pretty cautious about hydromorphone in dialysis patients. Really, my go-to drug is fentanyl. Fentanyl's available in a patch. It's involved in a oral or buccal medication. So it's good. Methadone is good too. A lot of people are not as comfortable using methadone. It's cheap. It's just you have to look for drug-drug interactions and know a little bit about what you're doing to use methadone. But I've used it very successfully in a number of dialysis patients to treat their pain, whether it's neuropathic pain, which is nerve injury pain, or nociceptive pain, which is more typically pain from muscle and joints. And then if it's neuropathic pain, that's the burning, tingling, stinging, shooting, stabbing type of pain that they might have with a diabetic peripheral neuropathy or with a neuropathy due to a vascular access steal syndrome. Again, gabapentin has been found to be helpful. Typically, you don't want to go above 300 milligrams a day since it makes many patients sleepy. You often want to give the doses at night, and sometimes 50 or 100 milligrams at night, or 200 milligrams at night, or maybe even 300 milligrams at night are all you're going to use to see if it helps. Occasionally, I've seen some dialysis patients tolerate up to 600 milligrams a day, but that's not common. And then pregabalin, the brand name for that is Lyrica, also works well the way gabapentin does. They're both considered gabapentinoids. The problem with pregabalin, in my experience, is that it's expensive and a lot of insurance doesn't pay for it. And so patients don't like it because it increases their out-of-pocket costs. And notice that just like with gabapentin, gabapentin, 1,800 milligrams, 2,400 milligrams a day, you might use in somebody with normal kidney function, max dose. And pregabalin, you might use up to 300, even 600 milligrams a day. But in a patient with kidney failure, really doses up to 75 or maybe 100 milligrams a day are pretty much the max you might want to use. Now, the other drug that's not on this list that also is a safe drug, perhaps the safest of the opioids in patients with kidney disease, is buprenorphine. And buprenorphine also doesn't have as many reactions with other medications as, for example, methadone. But buprenorphine is another drug where you need to be very aware of what other medications patients are on. And if the patient's on buprenorphine and somebody's starting an SSRI or another medicine, you need to follow those patients carefully to see if they're going to either be more symptomatic or less symptomatic because of drug-drug interactions. Now, in the middle column is tramadol, and in kidney disease, the limit it to 100 milligrams a day max. I think we've all heard of mental status changes and seizures in patients who've taken too much tramadol. So tramadol is really, it is an opioid, even though it was initially marketed as a non-opioid. And it's one that you ought to have some caution with. And then hydrocodone, oxycodone, which is available, as generic, as Lortab, as Norco, a lot of different ways it's out there. And there's really not a whole lot of evidence about its safety or lack of safety, but I can tell you there have been a lot of studies which hydrocodone has been used safely in dialysis patients. And you can say the same thing about oxycodone. Not a ton of studies out there. I myself have done a study using oxycodone. We didn't have a single patient stop the study because they had intolerable side effects. And then if we're dealing with neuropathic pain, and for one reason or another, your patients don't tolerate gabapentin or pregabalin, they get too sleepy, other drugs, desipramine and nortriptyline, are tricyclic antidepressants. And as long as your patient isn't having active heart disease, you're not dealing with arrhythmias or angina, desipramine or nortriptyline are a good alternative. They're much cheaper. And in fact, when a review a few years ago was done, the tricyclics, which includes desipramine and nortriptyline, it was a lower number needed to treat to get improvement in patients' symptoms. So these are good drugs too to use for neuropathic pain. And then this is the sort of for how do you start? And if you're starting with adjuvant therapy, this is talking about maybe starting with gabapentin and how you might titrate it up. Or if gabapentin doesn't work, you might go to carbamazepine. And then a third line would be, I talked about nortriptyline and imipramine. If the patient already is having trouble sleeping at night, you might want to go with amitriptyline. Some of us are old enough to remember when it was a brand, it was Elavil, or Doxepin. These are drugs that people could take at night that would help with neuropathic pain, but also might help patients sleep. If it's not neuropathic pain, if it's nociceptive pain, bone and joint pain, then you might start with acetaminophen. And this was a recommendation. Notice this was Sarah Davison in Canada. She went to hydromorphone as her second line drug. I talked to you about maybe going to oxycodone instead as your second line drug, maybe even as little as 2.5 milligrams of oxycodone immediate release to start with, and then titrating slowly. And also, of course, not forgetting other non-pharmacologic approaches, physical therapy, heat, massage, acupuncture, whatever things are available to you to try and treat your patient's pain. And of course, then you can always use topical agents as well, and those sometimes can be helpful. So we're moving right along here. let me pause, Kelly, ask about any questions about pain. It's important when you're treating a patient's pain to do a couple of things. One is to be clear whether you're dealing with neuropathic pain, which again is nerve injury pain, and that's where you're having shooting, stabbing, numbness, tingling, burning type of pain, or nociceptive pain, where the pain sensors are intact and they're accurately reporting pain, typically from muscles or joints, back pain or shoulder pain. Are examples. And the medicines you might use would be different. Again, the gabapentinoids, the tricyclic antidepressants for neuropathic pain, and the starting with acetaminophen and working your way up with nociceptive pain. Comments, questions, thoughts? If not, I'll keep going.
Nothing currently.
Okay. All right, so let's get into anxiety and depression then. And depending upon which study you read, anywhere between 25 to 40% of patients, dialysis patients, are going to report depressive symptoms. And I don't think I have a PHQ-4 among my slides, but let me just say a word about the PHQ-4. Oh, yes, I do. I have it on my next slide. Okay, so I will describe Patient Health Questionnaire 4. And again, that's something for free you can download and use, and I'll describe what it is. But you can use it. It's a very simple, easy tool to use. Give it to the patient, have them circle it, or have their family member with them circle to each of the 4 questions. And you can then see if they score 3 or higher on the 2 anxiety questions, or 3 or higher on the 2 depression questions, then really that suggests they should be more formally screened. And so first of all, of course, you have some sort of standard screen, or you're just aware the patient seems to be very anxious or worried or depressed. And then you do your initial screen with a PHQ-4, and then you might then use a Patient Health Questionnaire 9, which is obviously 9 questions instead of 4, or a general anxiety disorder, that's the GAD-7. These are, again, more complete assessment tools. And then you might refer them for comprehensive psychosocial evaluation, and they might be treated as comes over here. First line treatment could be medication, or it could be cognitive behavioral therapy. And there have been some studies that have suggested that medication and cognitive behavioral therapy work about equivalently well, but of course, medication may take 4 to 6 weeks to kick in if it is going to work, and it only may work to a moderate degree. In cognitive behavioral therapy, you may see improvement within the first week. And sometimes patients say, I'm taking enough medicines already, I don't want to take any more medicines. So if you have a psychologist or a social worker who is licensed to do cognitive behavioral therapy, you might want to reach around in your community and see if that resource might be available to your patient. So that would be treatment for depression. Treatment for anxiety. And by the way, so the medication that's most typically used to start with and best studied probably is sertraline. Its brand name is Zoloft. And there are articles published, studies done in dialysis patients on treating depression and seeing, again, moderate results. It wasn't, out of the ballpark results, but at least it did help patients somewhat to a significant degree. And then treating anxiety, again, you could be using a selective serotonin reuptake inhibitor, and you can be doing cognitive behavioral therapy. And of course, supportive counseling may help as well. But this is sort of a first have a suspicion, then use something like the PHQ-4 as your initial screen. And then if they screen 3 or higher on either one of the components of a PHQ-4, then you send them for more comprehensive psychosocial evaluation. Now, here's the PHQ-4, and it's readily available. And it says, over the last 2 weeks, how often have you been bothered by the following problems? So the first 2 questions are the anxiety questions. The second 2 questions are the depression questions. So how often over the last 2 weeks have you been bothered by feeling nervous, anxious, or on edge? Not at all, several days, more than half the days, nearly every day. Notice if they say nearly every day, that's a 3, and already they, the designers of this test say that you should be referring them for further evaluation. They may, however, say, oh, I'm only really nervous, anxious, or on edge only several days in the last 2 weeks, so they'd only get a 1. And then over the last 2 weeks, how often you've been bothered by not being able to stop or control worrying? And they might say more than half the days. Well, the 1 from the first question and the 2 from the second question would give them a 3. And again, they would then meet the threshold to being referred for further evaluation for their anxiety. Similarly, for depression, over the last 2 weeks, how often have you been bothered by feeling down, depressed, or hopeless? From not at all, which gets a 0, several days a 1, more than half the days 2, nearly every day a 3, or how often have you been bothered by having little interest or pleasure in doing things? And some of you may know the technical term for that is anhedonia, and that's a sign of depression, when people who are usually interested in seeing how their sports team is doing have no interest in turning on the TV or listening to the radio, hearing how their team's doing. That can be a sign that they're depressed. And again, you would grade the depression and refer if they score a 3 or higher. That's not to say that you wouldn't talk to them, you wouldn't encourage them. And if they're interested in counseling or interested in medication, even for a 2, that you still might evaluate them and treat them or refer them for treatment. Now, why are these things important? Well, not only do they decrease patients' quality of life, but anxiety symptoms are independently associated with increased risk for hospitalization and death in hemodialysis patients. And in hemodialysis populations, mental health is as important as comorbidities, how many major medical problems they have, heart disease, lung disease, cancer. And then, so mental health is as important as these other conditions and symptoms in determining quality of life. So ideally, social workers should be deployed as they are trained, and I'm probably going to hear if there's social workers listening, they'll start clapping. You should be allowed to attend to the psychological status of your patients, not merely transportation and insurance needs. And this isn't just me. This is an article in the American Journal of Kidney Diseases from 2 years ago. And you can get that reference at the bottom there and print it off and show it to your supervisor. Good luck. Cognitive behavioral therapy is safer and more effective than benzos, so more effective and safer, because benzodiazepines in dialysis patients, especially older patients, can be associated with an increased risk of motor vehicle accidents, falls, hip fractures, and even earlier onset of dementia. So we are really trying to stay away from Ativan, lorazepam's its generic name, or clonazepam is Klonopin, or Xanax, alprazolam. You're probably familiar with all of those, but the recommendation is really to try and stay away from them in dialysis patients and patients with chronic kidney disease. And we really need mental health therapists to be more widely available to patients with kidney disease. And I would really love it if a psychologist was available to dialysis patients on a regular basis. There are some dialysis organizations. There's one, for example, in New York City, a very well-known one, where they have a full-time licensed psychologist on staff to manage their patients. So what are the treatment options for depression? We talked about the SSRIs and the pharmacologic interventions, or citalopram, escitalopram, fluoxetine, sertraline's the Zoloft that I mentioned. I think one of these is Celexa and Lexapro. And I think this may be, I'm not sure what's the brand name for fluoxetine, but these are familiar SSRIs. Notice cognitive behavioral therapy was equally as effective, and it includes psychoeducation, behavioral activation, cognitive restructuring, healthy living, anxiety management, really promoting positive activity schedulization, motivational interviewing, reframing negative beliefs into more adaptive perspectives, adherence to a healthier lifestyle, and ways to manage anxiety. So uremic pruritus, I guess let me get to this, and then I think we're just about to the end. Let me see where we are. Okay, so let me move along then. I've had so much fun talking here. UP is uremic pruritus. It's a very troublesome symptom, as I've suggested to you. Again, a stepwise approach with validated assessment tools and non-pharmacologic, and then pharmacologic approaches should be utilized. If non-uremic causes are present, evaluate for them first. So you always want to treat the calcium and phosphorus imbalance, try and get them back to normal. The degree of dry skin, make sure they're eating well. And if dry skin is noted, good skin care and moisturizer with glycerol or high water containing emollients are first line treatment. And then if localized, you can consider capsaicin, but as an ointment that usually burns. Patients don't like it so much. Here's another cream that they could use. And then if the creams and the topical therapies just aren't cutting it, here's gabapentin, which we mentioned already, or pregabalin, or phototherapy. We forgot UVB therapy. That has been shown to be effective in some patients. Acupuncture, if it's available, is effective in some patients. But the point is you really need to have a plan, a systematic plan, step 1, step 2, step 3, step 4, because it can be such a heavy burden on patients, so troublesome to them. And so this is an approach for symptom management in your dialysis center. And the challenge is to have a system to routinely screen patients for pain and other symptoms. And the suggested strategy is to routinize use of one of these screening tools once a month or on each visit to a CKD clinic once a month in the dialysis center, each visit, and record the answer in a place in your electronic medical record so that you can, as Megan suggested, score the patient over time and see if you're making a difference. And then, of course, the challenge is that many clinicians do not know how to treat pain and symptoms. So it'd be great if you have a champion who really wants to dig into this and learn and maybe take some courses in palliative care for patients with kidney disease, or even look at the resources that I'm going to mention. And then an appreciable number of patients with CKD and SOD might have substance use disorder. And then again, somebody on the staff is going to need training in safe prescribing to opioids. And then if the nephrologist just doesn't have time, then another staff member is going to need to be designated. All right, so I promised I would give you, and these are on the slides that Kelly has promised she'll send out to you, all these great places, the British Columbia Renal Symptom Assessment and Management. This is algorithms for treating all the symptoms we've been talking about. Then in Alberta, the Canadians are really good at this, the conservative kidney management guidelines, and then the Edmonton symptom assessment tool that we mentioned, and the integrated palliative outcome score tool that we mentioned, and the PHQ-4, here's where you get that. And then the people in Australia are really good. In New South Wales, they have a renal supportive care program. They publish widely on their very good results, positive results. And here's their website where you can get all their tools. So just a word, if you have liked this discussion, there is a textbook that you could purchase, Palliative Care and Nephrology, which goes through a lot of these issues that we've talked about: anxiety, depression, pain, other symptoms. And I encourage you, it's from Oxford University Press. And then we actually have just finished an intervention to improve treatment of dialysis patients, identification of those who are seriously ill, having conversations with them. And so this is an abstract that you could find and read if you're interested. So in conclusion, symptom assessment and management are important to patients with kidney disease, and they improve patients' quality of life. At present, unfortunately, neither assessment nor management is done well. If we are truly going to improve the care of our patients, we need to systematically attend to their symptoms. There are validated tools to assess and algorithms to treat the pain and symptoms for patients. And clinicians treating patients with kidney disease need to acquire some primary palliative care knowledge and skills in assessment and management to do a job well. And so I would encourage you, those resources, those websites that I showed you. And then also you might want to purchase that book, Palliative Care and Nephrology, which really is sort of a handbook. It was published by really all the national and international experts in palliative care for patients with chronic kidney disease and on dialysis. So Kelly, let me stop there. What questions do you have? What comments? What should we discuss?
Right now, no questions. I'm waiting to see if any come through as you're wrapping up here.
Okay, all right. Well, so that I can see the chat function too, let me, oh, maybe I'm not getting the, Yeah, I'm not seeing the chat. Okay, well, I've certainly pointed to a number of resources, and I would hope that you would avail yourselves of them. And as we said, starting out in the very beginning, this is very important to your patients, really to improve their quality of life, to improve their overall sense of well-being. And so I do encourage you to maybe redouble your efforts to seriously look at the things that we discussed today.
Dr. Moss,
Yes.
May ask if you can briefly talk about end-of-life care in the remaining minutes that we have.
Sure. Yeah. Well, that's a whole week of talks, but yeah, so the book Palliative Care and Nephrology is very helpful. The Coalition for Supportive Care of Kidney Patients has a number of resources on the website. Really, end-of-life care starts with identifying what's important to your patients and really doing shared decision-making and advanced care planning. And once you've identified who they prefer to have as a decision maker and what types of treatments they would or would not want at the end of life, it would be appropriate to complete advanced directives and to complete medical orders like a physician order for life-sustaining treatment or a medical order for life-sustaining treatment. Over half the states have the type of medical order form or medical order set in their state, and it's available to use. And I would especially urge you to prioritize for who you should be talking to about these issues are those patients that you think are seriously ill. And the Pathways Project just completed a study in which we asked nephrologists at 10 different dialysis centers around the country, and they identified that 18% of their patients they thought were seriously ill. And sure enough, they were right. Those seriously ill patients were 8 times more likely to die during a 9-month follow-up than ones that they did not identify as seriously ill. So you might even want to use the surprise question in your dialysis center. Would I be surprised if this patient died in the next 6 months? And if you wouldn't be surprised, you might want to make a point of having a conversation with that patient to make sure you know who the patient trusts to make decisions for him or her if the patient gets too sick to make them for himself, and if there are treatments the patients would or would not want at the end of life. And somebody just said we have serious illness conversations with all our dialysis patients and documented in the electronic medical records. The palliative care team has a guide. That's great. I mean, I would wish that's true of all dialysis centers, but I can tell you, you're way ahead of the game. And when we did a study a few years back, only about 5% of dialysis centers really are doing a good job with kidney supportive care and end-of-life care management and advanced care planning. Well, I think we filled in our time. It looks from the comments like people have found some useful things that they're going to be able to take away from this. And again, Kelly, send everybody the slides and then they can click on the links and they can access the different resources we discussed. And then you will all be empowered, or I should say deputized. You're all deputized. Raise your right hand and take the pledge that you're going to do a great job managing your patients' pain and symptoms and improving their quality of life. So any final comments, Kelly? I guess not. All right, well, thank you all very much. Thank you for your attendance. And I think there are some evaluation forms for you to complete as you check out. So evaluation and maybe getting, I don't know if there's continuing education credit forms to fill out or not. Thank you very much.